Good evening, everyone. Warm welcome to the fourth day of Oral Cancer E-Conclave organized by ICanCaRe Sterling Cancer Hospital and FHNO, Foundation for Head and Neck Oncology. We are on the fourth day. In the last three sessions, we have had prolific discussions about challenges of diagnosing an oral lesion, about the early oral cancers, about locally advanced cancers. We saw about the treatment. We saw how beautifully the panel discussion gave solutions to very challenging cases. And here we are today on the fourth session where we're going to discuss and talk about the rehabilitation and follow-up of the oral cancer patients.
So we move on to our next session. Again, a very important topic about Trismus care. And to chair this session, I will again request Dr. Swatantra to kindly help us out and chair this session by Dr. Reena. The speaker for this session is none other than Dr. Reena R. Kumar, who is the Academic Director of ICanCaRe also. Over to Dr. Reena, please.
Thank you, Dr. Meenu. Thank you so very much. Thank you, Dr. Swatantra, to be my chairperson here. It's indeed a pleasure and an honor. And thank you for this. Thank you so very much. And it's a pleasure and honor to be here and speaking at the E-Conclave in this very important month of oral cancer awareness. And this program, jointly organized by ICanCaRe, FNHO, and as well as with Sterling Hospitals, brings out so many months and so many weeks and so much of learning and collaboration that we have achieved over the last few weeks. So what I have been given is an important topic of trismus. Now, trismus, when you look at it, I'm a dental surgeon, as you just all heard, but at the same time, I'm very proud to be a specialist in tobacco cessation, a tobacco intervention specialist. So when I look at this trismus terminology, and when we look at different definition of it, it would be commonly referred to as, something which is causing a tetanic spasm of the muscles of the mastication. And basically, it's a restriction of the jaw movement, which is happening, and of the temporomandibular joint. So when we look at it, it could be divided, basically, we could divide it into different categories. So we could say it could be because of the intra-articular causes, the extra-articular causes. It could be because of infection, trauma, neoplasm. And also amongst all of this is whether it is trauma, surgery, radiation. So we look at this particular part of trismus as which could be either a disease entity by itself. It could be a disease entity by itself, or it could be an iatrogenic problem which is happening. Now, how do we go about looking at this very important aspect of it? Would be, I would say that we would consider it that the normal range of mouth opening, that is at the interincisal, between the two incisors, would be around about 30 to 40 mm, being more in the males and of course less in the females. So we'd go up to 50, 55. So we'd say that anything less than 35 would be considered to be restricted mouth opening. So the restricted mouth opening could be measured as, it could be graded as light, moderate, or severe. We could put it down in millimeters as between 35 to 26, known as mild or grade 1, between 25 to 16 as grade 2 or moderate, and between 15 to 0 as grade 3, or it could be really, really a severe. So now what really happens in such a situation when there is a restrictive movement? So when there is a movement, restriction in the movement, obviously the person is going to be in a quality of life is going to be hampered, because this person is not going to be able to. We just had a fantastic talk on nutrition by Dr. Vikram. So that is one of the major important factors which is going to get affected, because there is going to be difficulty in mastication, difficulty in the nutrition factor of it. The person is not going to be able to eat, and there is going to be impaired speech, difficulty in speaking, compromised oral hygiene. So along with that comes a whole lot of other issues, because there is going to be difficulty in conducting one's everyday activities. Also, the speech is going to be defective, because why is that? Because the amount of oral cavity and the size and the amount in which the air is going to resonate inside the oral cavity is now diminished. As a result, the speech gets difficult. So the person's positioning in society becomes different. So because it is the Oral Cancer Awareness Month, and because we are in this forum that we are, yet let us start looking at where would we start looking at trismus. So Dr. Pavan gave a very nice insight into it by talking about oral submucous fibrosis. So oral submucous fibrosis is a precancerous lesion. It's a chronic insidious scarring which happens with juxtaepithelial inflammatory process, which is followed by fibroelastic changes in the lamina, which is going to lead to stiffness of the mucosa, and there is going to be trismus, which is going to be evident in these patients. So this is betel nut chewing. This is, of course, we have our pan masala, a smokeless tobacco, chewable form of tobacco, and other forms of tobacco that we have, because of which we have this trismus which is there in our patients. So oral submucous fibrosis is one side of it. Very important to have an early diagnosis, which we have discussed in the first module of our E-Conclave. And then when we look at the other things, when we look at surgery, radiation. So now most of our patients of head and neck and oropharyngeal cancer are all nowadays being treated with some level of chemotherapy, some level of cancers, some level of radiation, some level of surgery, various interventions that we have all talked about and discussed. Now, what is the muscles, or what is the anatomical issues which is involved over here would be the elevator muscles, basically the masseter, the temporalis, and the medial pterygoid, which would be involved. And these muscles are really strong muscles. They exert much more forces compared to the opening muscle, the antagonistic muscles. So as a result, anything which causes a trismus or a little shortening of these muscles is going to really close up the mouth. And we have moved a long way in our treatment of oral cancers, we have moved from the conventional 2D RD to the 3D through the 3D CRT, and today with the IMRT, and where there is an modulated, let's say, radiation therapy going on. Yes, but then there are areas where the amount of radiation which is being given out is much, much more. So if there is a radiation which is more than 60 gray, we know that there's going to be some amount of damage in those tissues over there. And there is going to be muscle guarding. And these patients are going to be having a lot of issues with the scar tissue production, the damage in because of the radiation, and resulting in difficulty in swallowing, difficulty in eating, difficulty in speech, difficulty in, because of the limited mouth opening, there is going to be a compromised airway clearance, making mastication of food extremely difficult. So all this leads to very poor quality. The combination basically of compromised mastication, poor bolus formation because the tongue cannot move, and the increased residue from the potential leads to the aspiration also. So such patients are debilitated as it is. Along with that, there is a huge fear of aspiration. So in such situations where we come in now, so what also happens is, what we have to worry about is, if there's a muscular problem, the epithelial problem, whatever be the problem, or because of the radiation or scarring, that because of which there has been trismus in this patient of ours, along with that, now the joint has got immobilized. So any joint getting immobilized leads to degenerative changes in the joints also. So we know that even 3 to 4 days, if the regular movement of the joint is not happening, or the muscle movements are not happening to this, at least to the minor limitations that it reaches, that we know that there is going to be some amount of problem, degeneration, which is going to happen. So these issues of trismus, the trismus as a entity is going to be associated with, the patient is going to complain of pain. We just talked about the other various things. So what is it that we are looking at? So of course, it is a symptomatic relief, making sure that the patient does not have the edema, the pain, the difficulty. So getting that out. But the important part is getting it into the passive movement, passive and active motion, which has got to be brought in, such that there has to be, along with that, significant reduction of the inflammation. So how does this happen? How is this really brought about is what we have to look at. So one is, of course, looking at massaging the area, the muscle itself, massaging with finger massage, using warm water, using warm, moist towels to be placed over the area, allowing that some maybe certain amount of drugs to be put in. But the important thing is also to see whether the neck mobility is being affected in these patients. And the important thing is to see whether we give some analgesic therapy, some soft diets, muscle relaxants, yes. But the important and the most important part is, how do we start now doing some active and passive stretches of these muscles, getting the joints to be moved, but Of course, there's a care to be taken. There are certain diagnostic features to be seen. Is there, what really is the cause? It should not be there's a trauma there and, we have actually started moving things. So there may be some, we may need to take a CT imaging of the joints to actually check if everything is fine, and then start with gradual opening of the mouth. So the traditional methods which have been used could be large number of small gadgets which have been placed in the mouth, and of course everybody knows about the terabyte jaw motion rehabilitation method. So by which you can measure the amount that the patient is opening and calibrate it and see how much is the interincisal. Now, this is a very expensive modality which is there. It's a very expensive modality. It's a fantastic modality put out by the Pittsburgh University, but it is expensive. And the other simplistic ones which we have in the form of spikes and, rubber molds and things like that do not really give us any objective assessment. So we are not really able to assess it. So if we really need something, so we would need something which is cost efficient. So it's not that because it is cheap, it is not effective. So it needs to be cost efficient, at the same time, very, very effective, and objectively can be assessed as to whether our patient is achieving the results and whether we are able to give them that relief and bringing about the opening of the mouth and progressive betterment of that particular problem, increasing the blood flow, relaxing the muscle, bringing about a better quality of life. So at ICanCaRe, we have a product which has been developed with research from Gujarat University at the JUSEC, where we are incubated. And this product is known as TrisCare, very appropriately, because it is a Trismus care product. So I will invite with this, basically that we go on now to look at, if I have to summarize what is Trismus, so I would go about by summarizing that it could be because of trauma, surgery, radiation, iatrogenic, or a disease entity by itself. Yes, causes a whole lot of debilitating problems, starting from speech to nutrition, to the difficulty in conversation, to be able to be having the regular oral hygiene, and airway could be causing a problem to the patient of aspiration. So as a result, the whole thing is about managing this. So first thing is looking at whether the patient is a tobacco user. So is there any oral submucous fibrosis? Moving in, because this is a progressive problem. So at grade 1 itself, to stop it, get into good habits, tobacco cessation is an important part. And when the patient has a limited jaw opening, to get into the jaw movement rehabilitation by using the appropriate product. So at this point, I will hand over to Shruti probably, and she will take us through, I think I will hand over to the chairperson first. I'm sorry for that. I should hand over to chairperson, because I have attempted to give a complete overview from a perspective of a tobacco cessation specialist, from a dental surgeon, and of course from keeping oral cancer as the king, the problem that we have to really solve, because the treatment aspect of it requires radiation and a lot of scarring which happens, and managing trismus is bringing back a lot of the quality of life for our patients. Thank you, Dr. Walia.
Thank you, Dr. Reena. It was, as always, very nicely captured and beautifully expressed. So indeed, Dr. Reena, as always, we were again enlightened by you.